Hello and welcome back to the channel. My name's Dr. James Gill and you've joined me for another clinical skills video. Today we're going to be talking about how to actually use the stethoscope. Now, many times we've seen it used in practice in terms of respiratory and abdominal examinations, but a lot of the time we're simply talking about where you're listening rather than what you're actually listening for. So I thought it might be worthwhile to go over using our famous tubes and what it is that we're listening for on a cardiovascular, on a respiratory and on an abdominal examination. Let's deal with the cardiovascular first because that's probably going to be the most tricky. Now, I suppose the big thing is, why do we have a stethoscope? And more importantly, what does it mean? Because that tells you about the history, which personally I find fascinating. This was first developed in 1861 by René Lamarck, literally because he didn't want to put his head on a female patient's chest, hence the derivation of the name, stetha being breast, scope being to observe. So this is a device for observing the chest. So with that understanding, essentially you could view the stethoscope as a way of keeping your patient at nearly arm's length. But realistically, it's allowing us to get a better quality auditory experience of what the patient is exhibiting. So I could put my ear on a patient's chest and I'm going to hear a series of sounds, but with the two heads of the stethoscope I'm able to listen to different sounds. So what do I mean by that? Well, we've got the two heads, we've got the diaphragm and the bell. And the bell is for listening to low sounds, and the diaphragm is for listening for high-pitched sounds. A good way of remembering that is that you will toll a bell, so that nice deep bong, but conversely, when it comes to singing, you would sing a high note from the diaphragm. So that's how I've always kept the two in my head, but it's actually really important, particularly from a cardiovascular standpoint, which is why we're going to go there first. So we all know that when you listen to the heart, we're going to hear two sounds. We're going to hear lub and dub, the heart sounds as it were. Medically speaking though, we're going to separate those into S1 and S2. It's identical, we're just changing the words. But it's important to understand what those sounds represent. They are the beats of the heart, but they're not actually the contraction of the heart. The lub and dub, S1 and S2, are due to the closure of heart valves. So we hear a snap, lub, and then a dub that we're going to pick up with the stethoscope. So S1 are lub noise, that's due to closure of the tricuspid and mitral valves. Conversely, the dub, or the S2, is the closure of the aortic and pulmonary valve. And that's really the basis of listening to the heart, because we can then add in extra noises. So if we step back ever so slightly, if our S1 is closure of tricuspid and mitral, and our S2 is closure of the aortic and pulmonary valves, we know that after S1 we're going to be in a systolic phase, so the heart is contracting, and F2 we're going to be in a diastolic phase, the heart is relaxing, i.e. filling. Now that's very important because we can have an S3 sound. Now this is normal in children, in pregnant women and in athletic individuals under the age of 30. And that's very important because of what it indicates. The S3 is literally due to the splash of blood being forced into the ventricle in the diastolic phase. Now that's very important because that S3 sound, that splash, has got to be seen in a young person with their heart rate going much faster normally, a pregnant person with a increased hyperdynamic circulation, and an athletic person who's probably got that much larger heart, so the splash is much more likely to come through. Now, that's not to say that an S3 can't be pathological. It can be seen in cardiomyopathy and also in aortic or mitral valve regurgitation. So we're going to get those added sounds or split heart sounds, as it were. But for the vast majority of the time, it's not an abnormality, which is one of the reasons why I've tried to listen to it on my pregnant wife downstairs. Unfortunately, I couldn't get a good recording of that S3 sound. So the S3 heart sound will occur in early diastole. That's very important with regard to the timings. So we're going to have our S1, our S2, and then we get the S3. So we've had the first two normal cardiac sounds first, and then the addition. So, given I can't get you that sound, how do we hear this S3 sound? Because we've got a lub, we've got a dub, we've got our S1, we've got our S2, so they're going to be nice, sharp sounds as the valves close. But our S3 is more of a splash because it's blood hitting the ventricle. It's a quieter sound. Now, at medical school, we would always use the memory trick of saying that it sounds like saying Kentucky, Kentucky. That never really made a huge amount of sense to me. I understand what's being said, it's about the timing, but it works better if you tap it out on your legs. So the S1 is going to be a nice slap on the leg, and S2 is going to be a nice slap on the leg, but your S3, because it is diastolic and it's a quieter sound, is more like a stroke on the leg. Have a look and see what you think with that. Kentucky, 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 Kentucky. So that's my way of understanding what an S3 sound is. But what about the S4? That's going to come in late diastole. So it almost sounds as if it becomes before our S1 and S2. It's very bizarre in that sense, but actually we've got S1, we've got contraction of the heart, we've got S2, diastole, and then we've got the S4 at the very end of diastole before we get the tricuspid and mitral valve closing again. Unlike the S3, which can be normal, the S4 is always considered to be a pathological sound. Now, with our S3 heart sound being associated with a cardiac splash as blood hits the ventricle wall, we're still dealing with a similar movement of blood, but the timing has moved later. So the S4 sound is seen in cardiac pathology where we've got stiffening of the heart. So we still get the blood being forced into the ventricle, but unlike the S3 where we get the splash, we've got a problem with the right ventricle at this point. It's become hardened, it's become thickened. So rather than we getting the sound of a splashing, we get a shudder from the ventricle, causing that S4 heart sound. So because we know that the S4 heart sound is due to stiffness of the ventricular wall, that will often be seen in hypertension and potentially in aortic stenosis. So when it comes to listening to S4, we can again use a medical school way of doing it. If we're going to say that the S3 heart sound sounds like Kentucky, the S4 sound being in late diastole, so just before S1, actually sounds like Tennessee, Tennessee. We've got the S4 and the S1 coming relatively close together before the normal cardiac break, before our S2 sound. Again, you can actually tap this out on your legs And I find that a better way of putting it into my head, because we've got that softer sound of the S4 from that ventricular lack of compliance, and then our nice sharp S1 and S2 from the valve closures. Have a look at that now. So we appreciate that the S4 sound is pathological. The S3 sound might be pathological, but does have that little bit of wiggle room for it for some individuals. But this is about the stethoscope, so where are we going to listen to these? Let's drop back one step further and actually make sure we're all on the same page when it comes to where we're going to listen for the different heart sounds. So we know that S1 is due to the tricuspid and mitral zone, mitral valves closing. Therefore, we're going to listen with the bell over the mitral area. So fifth intercostal space, mid-clavicular line. We know that our S2 is caused by the aortic and pulmonary valve closure, so we're going to listen to the aortic area, which is going to be the second intercostal space on the right upper sternal border. If we want to listen over the Erb's point, that's third or fourth intercostal space on the left zone, that's going to give us a general overview of all of the heart sounds, but it is not as good to listen as any of the specific areas. In terms of the S3 heart sound, that's going to be very quiet, and we're probably going to hear that best over the mitral area. Similarly for the S4 heart sound. So I think we've got a good idea of the heart sounds now with regard to the stethoscope. So let's have a check what we'd be listening for when we come to auscultation of the chest. So to listen to the chest, we want to listen both front and back, and crucially, we want to get the patient to cross their arms over their chest in order to clear the scapula. When we're doing so, what are the sounds we're going to listen for? Well, the first is vesicular breath sounds. So this is the normal air movement within healthy alveoli, and it's what you should expect to find. So we're going to have a much greater inspiration than we would an expiration. Just think how you normally hear people talking. They're going to breathe in and then say something. That's what we have with normal vesicular breathing. In longer and shorter than the out. And we're going to hear this over healthy lung. Now, if we get a simple problem, for example, a pneumonia, a consolidation, a thickening almost of lung, that's going to give us bronchial breathing. Now, you can check that yourself with the stethoscope by listening over the trachea, because bronchial breathing is still a noise that the bronchi will make normally. However, it is audible in pathology, whereas it is not audible in healthy lung, because the healthy lung insulates that sound, so all we get is that vesicular breath sound. So when you hear bronchial breathing, you know that there is a problem there. And bronchial breathing might best be described as more like a snoring noise. So we've now got an equal inspiratory and expiratory sound, and there's no gap in the middle as we have with vesicular breathing. So we're going to see bronchial breathing in consolidation. Something is happening to that lung to mean that sound can transmit through it more easily. So we think of it as, being full of something like in a pneumonia, or perhaps a pleural effusion where we've got fluid affecting the lung. An additional sound that we might hear that is very similar to bronchial breathing and may even be seen in the same chest is a wheeze, that being a polyphonic noise on expiration. So you breathe in And on the breathe out, we get an extra noise. Now that's due to narrowing of the small airways. So for example, in asthma or potentially in reactive airways with hay fever. We have a contrasting sound there, that being a inspiratory stridor. The clue there being it's when you breathe in. But it's a difference, as you can see there. It's a lower, hollower noise and indicates a narrowing of a large airway, such as from a foreign body if it's stuck in the trachea, or potentially a tumour that's squashing one of the airways. Now, there is another polyphonic noise, but again a lower one. This is a Rhonchi. This is crucially seen where we've got secretions in the lung and they disappear when the patient coughs because those secretions have moved out by that forceful expulsion of air seen with a cough. Like our wheeze and our stridor being related sounds, we also have fine crackles and coarse crackles, which I would argue are at least related with regard to listening to the stethoscope. Our fine crackles are often described as like Velcro being opened and are high-pitched and are normally associated with things like pulmonary fibrosis. Conversely, coarse crackles often, for want of a better phrase, sound wet, and that's due to alveoli that have secretions within them opening up. So we're going to probably see coarse crackles in combination with bronchial breathing because it's often seen in things such as pneumonia, or if we've got fluid in the lungs, perhaps pulmonary edema due to fluid overload, or problems with the heart. We obviously can't forget my favourite chest sound, and that is a pleural rub. This is where we've got inflammation of the pleura over the lung, but also the pleura that is lining the chest wall cavity. So the visceral pleura, but also the parietal pleura lining the outside of the chest wall. If those become inflamed, you're going to get friction, and that results in this pleural rub. This is often described as a sandpaper type noise, or more appropriately, like walking on fresh fallen snow. And I kid you not, once you have heard it in a real pathological patient who might, for example, have pleurisy, you'll hear the creaking noise like walking on fresh fallen snow, and you'll never be able to hear it again properly, which is particularly appropriate because we've recently had snow in the UK. So I was out of the house at 10 o'clock at night, specifically recording my feet walking on snow to mimic that pleural rub. So whilst you probably can't write down like walking on fresh snow in your exams, technically you'd describe a pleural rub as a low, continuous creaking sound on inspiration and expiration, because it's all movement of the chest wall is causing that noise. I think that pretty much covers everything that we need to talk about on the chest with regard to using the stethoscope, apart from how we're using it. It's worthwhile highlighting that for the vast majority of these sounds, they're all of a higher pitch note than our cardiac sounds. Thus, we're always going to be using the diaphragm of the stethoscope. There's not really any role for the bell in the auscultation of the chest. The same is going to be true for the bowel sounds, which are the final thing that we commonly listen to. With regard to listening to bowel sounds, these are very crude sounds, and there's a large degree of debate as to when you should be listening. With regard to clinical skills, some people will say that we should listen to the bowel sounds before we palpate the abdomen. There's actually no good evidence to suggest that's required and or changes the outcome from the examination. So it would be suggested from research that you can listen to the bowel sounds whenever you need. To that end, what are we listening for with the bowel sounds? So essentially we're just listening for the movement of the gas and fluid and stool through the intestines. We should get bowel sounds in a normal individual. They can, however, become slowed if, for example, you may be taking codeine or things that could cause constipation. They can become absent if your bowel has stopped moving. So, for example, if you're post-surgery or if you've had a volvulus where the bowel is twisted. And potentially we can have a change to tinkling bowel sounds when there is an obstruction. Now, this obstruction could be cancerous or even just constipation, so backed up stool. The tinkling is from air and fluid being forced around that obstruction. Well, that completes our overview of how to use the stethoscope. Hopefully this has been a useful review for yourself, and hopefully you've learnt something with regard to the heart sounds and auscultation of the chest. If you've got any questions, please don't hesitate them in the comments below. And with that, I'll say cheerio and see you in the next one. Take care.